So it's a real pleasure to be here, and I first want to add my thanks and acknowledgments to the 25 students who put this program together. It's really amazing to see what you guys have been able to do. And I'd like to invite all of the 25 who are involved in putting this program to stand up so that we could acknowledge them. So please do stand up. Pat mentioned how this symposium has grown, but the amazing thing to me is that they put this whole thing on for something like $20,000 from the Puget Sound Partners, which, if we'd been organizing a meeting of this size, we'd be looking to raise $1.4 million or something like that. So it's the energy and the passion and the wisdom of these students who are able to pull this off. And I think I don't want to take any time away from Jim's presentation. That's who you came here to hear. But I will just say that our first priority for this new Department of Global Health is really to try to capture this enthusiasm of our students and carry their vision forward in our curriculum and the organization of our department. This is really our first priority. And we envision combining the education, training, and mentoring part of the department in centers that will also include the research and service activities that include global health and service and research-based programs. We're really thrilled by the excitement of the undergraduate students, the graduate students, the postgraduate students, the postdocs, the professional trainees. It's just almost a little overwhelming. But we really think that bringing these people, these students and trainees together with our faculty in interdisciplinary teams to solve some of the most complex problems in the world that are responsible for the health disparities that affect 5 billion people in the world whose health is much worse than the 1 billion people living in well-off countries. That's our goal, is to reduce these health disparities, and not only in developing country populations, but at home as well, as we think globally but act locally. And we hope to do this by understanding and addressing the causes of health disparities that we're trying to help solve and the global determinants of disease that affect all of us. So that's our goal. We think it's the right thing to do, the smart thing to do, and that we can do it with your help. And with the partners that we have in the Puget Sound area in Washington State, and I think with the inspiration of leaders like Jim Kim, who really set the direction for all of us. So, Jim, it's a pleasure and an honor to introduce you tonight. I have admired your work for so long. Jim was trained both as a physician and a medical anthropologist, so he got his MD and his PhD at Harvard. And he's been recognized in many ways. Some of the most interesting are that he was awarded a MacArthur Genius Fellowship in 2003. He was named one of America's 25 best leaders by U.S. News & World Report in 2005. And he was named as one of the 100 most influential people in the world by Time magazine in 2006. Now, I don't know if that's going down from being one of the top 25 to one of the top 100, but I don't think you have to worry about that. Jim has 20 years of experience in improving health in developing countries. He's a founding trustee and the former executive director of Partners in Health. And as you have heard from Paul Farmer, who also was a founder of that organization, Partners in Health develops a range of health program activities in poor countries around the world. Haiti, Peru, Russia, Rwanda, Lesotho, United States, and I think Malawi now is also on that list. Jim is an expert in tuberculosis. He has really contributed to international policy on tuberculosis, and particularly focused on treating multi-drug resistant tuberculosis and how to solve those problems. And he, most recently, at the World Health Organization, led the 3x5 initiative, trying to get therapy for 3 million people with HIV in the world and the poor countries under care by 2005. And he was truly inspirational in this role. And his efforts, I think, for those of us at the University of Washington involved in international service programs, really have directly benefited from his efforts in this regard, as many of our colleagues have been developing and scaling up clinics for HIV care around the world. So Jim returned to Harvard at the end of 2005, where he is now the Francis Xavier Bagneau Professor of Health and Human Rights at the Harvard School of Public Health and Professor of Medicine and Social Medicine at the Harvard Medical School. And interestingly, he's Chief of the Division of Social Medicine and Health Inequalities at the Brigham and Women's Hospital at Harvard, and Chair of the Department of Social Medicine at Harvard Medical School. And he was telling me that they are actually, excuse me, setting up a residency program in medicine initially, but now in other subspecialties that will extend the clinical training from 3 to 4 years and will ultimately lead to international experience and to a master's degree in public health. And we're very interested in talking more about that because that's the interest of some of our house staff as well. So, Jim, as I mentioned, was an intern classmate of Paul Farmer, who was the last person to fill up this auditorium recently, and also of Chris Murray, who may be the next. We hope he's the next, because we're trying to recruit him to the University of Washington. And I hope that Jim is going to tell us during his talk what it is they were feeding these interns during that year that made them all so incredibly productive. So it's really a pleasure and an honor to introduce you, Jim, to talk about this interesting topic, the golden age of global health. So Jim Yong Kim.
Thank you. Well, thanks very much. It's great to be here. I love coming to Seattle, and if you want to know how much I love coming to Seattle, yesterday in the middle of a blowing ice storm, I went to Logan Airport to take JetBlue, and and when I got there, I was supposed to leave at 6:30, and it had been delayed to 9 p.m. And they were playing CNN, and the thing that kept going on CNN over and over and over again is these people saying, "Outraged! I was on the tarmac for 8 hours. JetBlue is a disastrous airline." It's also a really great honor to be introduced by King. Now, let me tell you, from the HIV department at WHO, we knew King as one of the deans of STDs and HIV. And it's great that he's taken over this program. And I suggest that you listen carefully to him, because the other thing I know about him is that he was a varsity wrestler when he was at Harvard. Doesn't he kind of look like he will take you down at some point if you... And I chose this title for a very specific reason. One of my all-time heroes and a person that I'm proud to say I count as one of my mentors is Bill Foege. There's a Bill Foege building here. King is a Bill Foege professor. And I've just met very few people who are as gentle and yet so profound and have had such a huge impact as Bill Foege. He coined this term, the golden age of global health. I heard Bill Foege give a moving and just overwhelming talk when we all gathered in New York City, at Columbia University, to pay our respects, and to honor Alan Rosenfield, another close friend of King's and mine, and Pat's, who was the dean of the School of Public Health of Columbia. And Bill Foege said, "We are living in the golden age of global health. We're about 5 years into it, and 25 years from now, or 20 years from now, at the end of this golden age, we'll turn back and ask a simple question. What was it that led to the golden age of global health? And Bill said that we'll remember two people, Bill and Melinda Gates. And being here in Seattle, I feel it more and more. And it's not just Bill and Melinda Gates, it's all of you too here. I have recently been accused of actually spending way too much time talking to the Seattle press. But you have a great press here. You have really great folks reporting on global health. And in one of my interviews, and I think it was with Sandy Doughton, who may be here tonight, I said that, look, if it's not already, Seattle is soon to become the epicenter of global health in the world. And I hadn't seen the article in the press, and I had dinner that night with Barry Bloom, who's the dean of the Harvard School of Public Health, who basically said, Jim, would you please shut up about that? But I do think we're in the golden age of global health. And I'd like to just take you through, with an ethnographer's eye, part of my experience and how dramatically things have changed, and some suggestions humbly offered as to where I think we need to go in global health. Oops. So this is an old slide. You can see that technologically it's much more primitive than the one we had before. This is a slide I used to show at the end of my talks as recently as 2002. This was when very few people were on HIV treatment, literally about 40 or 50,000 in all of Africa. And I remember clearly this was my moment of drama. 25 million adults soon to be dead in sub-Saharan Africa. 40 million orphans by 2010. More cases of HIV in Russia last year than in all other years combined. India and China have hidden and explosive epidemics, and some of this wrong, actually. China thankfully has proven not to be so explosive as we once feared. TB and HIV are mutually incendiary epidemics. How will we define our generation? Now, very little money was around at that time. We really felt, Paul and I had been talking about the importance of HIV treatment, but as recently as 2001, we really didn't know whether it would happen or not. Some of you remember an article that we wrote with Jeff Sachs talking about the need to scale up HIV treatment. It was called the Harvard Consensus Statement. And this was 2001. And there was a strong reaction. People were saying the pendulum has swung too far in the direction of treatment at a time when not a single person was on HIV treatment in the world with bilateral funds, with funds from major donors. So at a time when we thought, the only thing we can do is just the simplest things. I mean, that used to be the motto of public health, the KISS principle, keep it simple, stupid. We can only do simple, straightforward things like vaccinations and others. And this was very recently. So what's happened? Well, this is from the UNAIDS. And as the number of people living with HIV has gone up now, over 30 million, you can see the various things that have been done. I'm not going to go through this, and these slides will be available to everyone. But toward the end, you see the UN General Assembly special session. You see President Bush's initiative. This is going to be quite a landmark. I mean, I think in looking at what we were doing in global health, I think of the Bush statement as almost like Bob Beeman's long jump at the Mexico Olympics. Does anyone know what I'm talking about? Yeah. All right. Bob Beeman was a long jumper who jumped 29 feet. That was just so much further than anyone else had jumped that the record stood for a very long time. And the encouraging thing to me is that when President Bush announced $15 billion and now $17.5 for HIV/AIDS in developing countries, it puts a lot of pressure on Democrats to do something bigger. And I think coming into 2008, we have to be sure that any new administration and this new Congress really ups the ante much more. What's the next step? That's for all of you guys to decide. But things have gotten better, and look at the money for HIV/AIDS. It's going to be over 10 billion this year. And I remember very clearly in 2002 when we began talking about a global fund to fight AIDS, TB, and malaria that would have 10 billion a year in it. People simply scoffed. They would say, you know, what in the hell are these guys talking about? There's no way there'll ever be $10 billion for HIV/AIDS or anything near that. It's just not realistic. Therefore, we've got to pull back on our expectations. Now, let me just say one thing here in front of all of you on UWTV. People have said, you know, Kim and Farmer, they just focus too much on treatment. But let me just tell you that HIV treatment has never been more important to us than any of the other things that we've done. We've never been more concerned about HIV than children who die of diarrheal disease. We've always been concerned about the full range because that's what we do in our project sites. But strategy is something different. What is it that's going to capture the attention of really powerful people so that they'll do something? We really weren't getting very far with HIV prevention. For some reason, you know, 3 billion condoms by 2005 just did not capture the imagination of powerful people. Saving lives did, and I think what we know absolutely clearly now is that the Trojan horse of HIV treatment, it's not just a Trojan horse, I believe firmly in it, but how much of this money is now for HIV prevention? You know, we had $100 million for HIV prevention back in 1999. Now we have billions of dollars for HIV prevention, and it was because rich people could get their head around saving lives and had more difficulty getting their heads around condoms. This is true everywhere. You guys are terrible. So, look, it was a strategic issue. We knew this. I mean, if you look at what gets funded in the United States, I mean, I've been raising money for Partners in Health for 20 years, and we know that it's treatment, saving lives, and disasters that lead to all the big donations. And there's no reason why that same principle wouldn't apply for governments, and it did. So, you know, I'm now sort of going back after my 3x5 experience. By the way, I call myself a recovering former WHO employee, and feel like I kind of have PTSD, you know, as a result of fighting that war. 3x5 was crazy. It was just nuts. It was a crazy goal to begin with. It was meaning that it was just so ambitious. But in the midst of all that, I was really accused of caring only about HIV treatment and nothing else. But that's not what I've been doing for the last 20 years of my life. And this is something that we've got to get better at. We've got to get better at the strategy. What is it that we can use to get our concerns in front of people, get people feeling good about doing something, and then bringing everything else in as we go along? Great things have happened in terms of prices. And let me just go over some things that are very relevant for Seattle. So when did the first major price drops, and I'm not supposed to use a pointer because the TV guys told me not to, but the first major drop happened starting around the summer, or around the late spring of 2000. What happened in the late spring of 2000 here in Seattle? Quite literally, because AIDS drug prices were on the agenda of the WTO rioters, and it was such an important issue, we saw soon after that President Clinton make his declaration that when we go to trade meetings, we're not going to only be concerned about intellectual property, we're also going to be concerned about public health. Literally days after that, the prices dropped. So Seattle had a role in these price drops. And let me also just be very direct, straightforward. You know, the pharmaceutical industry has made more contributions and donations to the AIDS struggle than any industry to any problem by far in history. You know, it's a record that we simply have to acknowledge and be thankful for. But it was politics and the social movements that led to that particular change. And Seattle had a big role. And any of you who were out throwing Molotov cocktails, I take my hat off to you now. Not that you should have hurt anybody. Not anyone. As long as we didn't hurt anybody. I mean, it was a brave thing to do, and it actually, I think, made a difference. Now, this is Joseph Jeune. Can everyone see this picture? Not well, sorry. This is Joseph Jun. He's one of our patients in Haiti, and he's now the most famous patient in the world living with HIV/AIDS, because I put his before and after pictures on every document that came out of WHO. And so this past August, we were in Toronto, and we walked, our team from Haiti walked by a poster from Kenya, and there was Joseph Jun's picture. And so they walked up to the folks and said, "Hey, that's Joseph Jun. He's from Haiti." And they said, "No, he's from Kenya." You know. He was from a northern district. I mean, they had the details on who he was and where he was getting treated, and they said, "No, he's Haitian." And they said, "No, he's Kenyan." So Joseph Jun actually was in Toronto in August because we brought him there to give a talk, and so we brought Joseph to that poster, and they were amazed, and hey, and they took pictures with him. But the point is, this picture was so profound that he became Kenyan, and he became Tanzanian, and he became Zambian, and the importance of this image, I think, cannot be overestimated. I was just in a meeting with Tony Fauci, who said that him going to see the Haiti Project and looking at these pictures of these transformed people are part of what convinced him to push forward for a treatment program for President Bush. So we've been doing this for a long time. We knew that this kind of thing happened. We call this the Lazarus effect of HIV treatment, and it's frankly something that folks in the United States don't see very much anymore, because we don't wait that long here anymore. But those pictures, and I was later to hear this from Minister of Health after Minister of Health from Africa, those pictures had an impact everywhere. They got a completely different sense of what was possible in Africa by looking at these pictures. Now, we've always thought, in Creole, they call HIV treatment cheval bataille, the battle horse. They're not quite so indelicate as to call it the Trojan horse. But it's the battle horse, because it's our first step. The people from the Arab countries would call it the camel's nose under the tent. It's that first step. And so here's Bukankare in March of '03, before we got Global Fund money. And what we told the Global Fund at that time was, look, we just can't do HIV treatment alone. You have to provide actual services. And so we talk about the 4 pillars, but generally speaking, it's that you've got to do TB treatment, you've got to do STD treatment, and you've got to provide maternal and child health services, including immunizations. If you don't do those things, people will never come to the clinic. You can't do a standalone HIV treatment program. So they actually agreed, the Global Fund, to pay for quite a few of those services. And so this is what it looked like 3 months later. And we found out that it was offering those services that would allow us to detect those patients. Now, I think that this is the Holy Grail. We need to find ways of linking all of this interest in the Joseph Jun transformations to building primary care systems. You know, when we at WHO, when WHO declared in 1978 Health for All by the year 2000, there really wasn't anything like a PEPFAR or a Global Fund that gave us a chance to really build those systems. You know, Jim Grant, to his great credit, tried to do it on the back of immunization and other programs, but it's so much easier to do it now because the sine qua non is chronic care. What is going to allow us to provide, to get the money to do chronic care? So we launched 3x5, and when I tell you it was crazy, it was, Dr. Brundtland, the predecessor to Dr. Lee, is actually the person who first announced the target of 3 million patients on treatment by 2005. She did it at the Barcelona AIDS meeting. But then as soon as she came back from Barcelona in July of 2002, she announced she wasn't going to run for re-election. So it sort of died there, it sat there. And when we took over in February, when we started our transition in February of 2003, the question for us was, the target's there. Do we back off, or do we jump in and try to make the best of it? Now, I acted like a WHO employee for 3 years, but I was basically still an activist. And so the activist in me said, absolutely, let's do this. And I'll tell you my reasoning. My reasoning was that the AIDS world, the multilateral AIDS world, had never set a concrete target with a concrete end date for ministers of health or developing countries. What had we done? We'd say, make a commitment. And, ministers of health stand up, hey, I'm committed to AIDS. And we said, come to a UN General Assembly special session on AIDS and make your commitment there. UNGAS, we called it. Can you believe UNGAS, we called it? So they came to UNGAS and they stood up and they made their commitment. And we said, not only do that, but set up a national AIDS coordinating body that will report directly to the head of state. Yeah, okay, we'll do that. Still no target, still nothing concrete that they had to accomplish. So I made the argument to JW, and this is after talking a lot with people in the quality improvement world, people like Don Berwick, who is one of the global gurus of quality improvement in healthcare in developed countries, and said, you know, without a clear target and a clear end date for all the non-PEPFAR countries, because there was a target for PEPFAR, but not for the non-PEPFAR countries, without a clear target and a clear end date, ministers and governments will not move. And Dr. Lee, having been around during Jim Grant's child survival movement when a target transformed that world, agreed. He understood the importance of those targets. Well, you know, we didn't make it. We made it to about 1.3. I think we're well over 2 million now, and we're going to miss the target by 3 or 4 years. Not bad in terms of geological time, which is about the equivalent of WHO time. It's not bad, but we didn't make it. And there's a lot of questions being asked. People have asked, well, you know, this setting of targets that you don't miss, isn't that bad? Isn't that a bad thing? Maybe, you know, I mean, as I look back, would I have done it again? It's a hard question to answer. Would I have done it differently? So one of the criticisms has always been, well, you should have consulted with us more extensively, because we did talk to some people, but you should have consulted with us more extensively before you declared this target. And then I asked the question, well, what would you have said to us? Oh, we would have told you never to do it. Look at universal access now. Now, there are a lot of great people working on universal access, a lot of really committed, wonderful people. Michel Sidibe, a very good friend of mine, is working his butt off trying to make that happen. But what have they done? They've taken it from the 3x5 activist movement kind of notion and turned it into the standard UN consultative process. There have been dozens and dozens and dozens of meetings around universal access. And guess what? All the targets, all the pressure, all the urgency has been effectively and systematically removed, in my view. Because that's what bureaucracies do. They effectively take pressure off of individual countries, individual people, because that's what it does best. So I think it was important to have a target. Were there mistakes that we made? Sure, lots of mistakes that we made. But I think most people looking back feel that it really did create momentum. And I learned a lot. I learned a ton. I learned a ton from this. I learned lots of things, including that a target and an end date without absolutely robust and rigorous plans and people around to actually do it makes a target like this awfully difficult. So there's tons of money now going into global health. This is, if you haven't all read it, you should look at John Cohen's article in Science talking about transformations in global health. Some $40 billion new dollars. How should we spend that? Well, I'd say that there are lots of different and good ways of spending that money, but we still have this problem. And these are the 10 million deaths that happen each year from conditions for which safe, effective, affordable prevention and treatment exist. So the 10 million burden is not doing what we already know we should do and not implementing what we already have to implement. Without question, one of the biggest problems, and you know, we can talk about this later in the question and answer, but the downstream issues are really implementation. When we've got these products now that we're not implementing. What's going to happen when we have new products? I'll talk more about that, but I want to take you through a very specific example. And again, MDR-TB, multi-drug-resistant TB, this particular issue and problem is not the point. I don't want to focus overly much on a particular problem. I just want to take you through a process that we went through to try to take all the steps necessary to take on MDR-TB in the entire world. And I'm going to tell you we failed in the end, and let's talk about that. So in 1996, when we started discovering patients with drug-resistant TB living in these shanty towns in Lima, Peru, in places where in a country that had the best TB control program in the developing world. And they really did. It was amazing. They went from very poor coverage, very poor detection with about a 50% treatment success rate to over 90% detection and over 85% cure. The program was run by a magnificent man named Pedro Suarez who was just doing great stuff. And when we found these cases, we thought, well, look, we've got some experience in Haiti treating MDR-TB, and we want to do it in Lima as well. We were responding to the need of the community because they were very afraid of these cases of people who were on treatment, getting second, third, and fourth treatments, and still sick and still infecting their loved ones. So we said, well, why don't we treat them? And the authorities said, no, don't treat them. And in fact, if you do treat a single patient, we will kick you out of the country. That was the first reaction of the authorities. And WHO was saying, it's too expensive, forget about it, it takes attention from other things, just forget about it. DOTS is the only thing that you should focus on. Well, of course, we started treating people. And the woman in the picture bending over is Nalda Angeles. She's she has a high school education. She lives in this community, and she was going to study to be a beautician. Well, we treated her, we trained her how to give caprimycin IM injections 6 days a week for up to a year for some of these patients. This is very, very difficult and complicated treatment. To make a long story short, we achieved about 85% cure rates in our first cohort of very sick patients. We went and we had a meeting in Cambridge where we brought together all the leading TB experts, and we convinced them that at least it's possible. Because at first they were saying it's impossible just clinically to treat MDR-TB patients in developing countries. But the next problem was the price. They said, well, even if it's possible, it costs too much. It's just way too expensive to treat them. And it cost us about $25,000 per patient per year. And they said, are you guys nuts? You know what we could do with $25,000 with regular TB? You should give all that money to us and just focus on regular TB. Well, we tried everything we could to find out where we could get these drugs for better prices. At first, we were calling state health authorities and borrowing caprimycin and cycloserine. And finally, we sort of just looked at the drugs. And Aaron Shakow, who's here from Seattle, was the one who did the research. And it was a simple question. Are these drugs on patent or not? When we asked the folks at WHO whether they knew, they said they didn't know. Right? And we found out that all of the drugs, except for one class, the fluoroquinolones, had been off patent for a long time. So here we go, a death sentence, folks, and we didn't even know that these drugs were off patent. So we formed a buyers group, and by this time, WHO was completely on board. They were incredibly supportive, and we formed this group, and the overall price reductions were between 85 and 98% in a year. So the point here is that we knew that in order to change the world for poor people living with drug-resistant TB, we couldn't just do a pilot project. We also had the responsibility of lowering the drugs. Now, I'm not suggesting that we did this alone. MSF was terribly important in helping us. They actually put the first $1 million up for the drugs. But at first, MSF was against MDR-TB treatment. And in fact, it took quite an effort to get them to change their minds on MDR-TB treatment. We've done well, we've scaled up. We're now in 35 countries. But as you can see, we've sort of hit the wall. 35 countries and 20,000 patients out of between 500,000 and 1 million that need treatment. Well, from 2000, when it was a death sentence, that's okay, but it's not enough. So we tried our best to do all the things that are needed, and we haven't done enough. We haven't even begun to touch India and China yet. And it gets worse. Because not only is there MDR-TB, now there's something that we're calling XDR-TB. Cases that are not only resistant to isoniazid and rifampicin, but to at least 2 other classes of drugs, especially the fluoroquinolones. Here's one study that's about as frightening as anything I've seen. In KwaZulu-Natal, KZN, they had heard about some cases where people with HIV, with TB, were on treatment and dying. And so they did a survey. 1,500 isolates, 544 culture positive. Of those, 41% MDR-TB. That's frightening in and of itself. But of the 41 with MDR-TB, 10% had XDR-TB. So extensively or extremely drug-resistant TB. Here's what happened to them. First of all, half of them, 51%, had never had any prior TB treatment, meaning they caught XDR-TB from someone else. Of those who were tested for HIV, 100% were positive. Of those who were tested, of the 53, 52 died. And the average time from diagnosis of TB to death was 16 days. We did spaligotyping. Well, I shouldn't say we, the group did spaligotyping. And they found that 26 out of the 30 strains studied were identical. So this is like a match going off in gasoline. And it's in KwaZulu-Natal. And we've just started a project in Lesotho, which is right next door. We are now finding, this is a country with 24 to 29% seropositivity in the adult population. And we're sure this is exactly the same epidemic. And so my colleague, Jennifer Farron, who runs that project, says that she thinks fully 25% of all the cases will be MDR-TB. This is absolutely frightening. And we have no choice but to take it on. This is South Africa. We've got to take on a dual epidemic now of HIV and MDR-TB. And what are we going to do? Where are the insights? Is it just about treatment protocols? This is a management challenge of absolutely historic proportions. We're there, luckily our group has had experience in both HIV and MDR-TB, but seasoned veterans of public health are telling me that they've never been so scared of something. But this is what we've got, folks. This is the modern world. This is the challenge, at least one of them, of global health. So we've got all these new investments. Should we invest in basic science research? Absolutely. I couldn't agree more. We need much, much more money for basic science research, especially basic science research that can help us with these problems. We need new drug targets. We need new drugs for TB immediately. And it can't be just one or two. That's not good enough for XDR-TB. We need 4 or 5 new drugs that we can test at the same time. Basic science research is going to be critical to discover those new drugs. Clinical research, absolutely. We need to know what works and what doesn't work. We don't really even have a good idea about using second-line drugs and ARVs. There's just so little experience with that. We have no guidelines, and so we're going to work on writing them right now. New technology, you bet. There's no one who wants new technology more than we do, those of us who work on MDR-TB. But if we're not better at implementation, what's going to happen? All these new products, there is no theory of hydraulics that says putting a new and improved product on top of a lot of old ones that are not being delivered will somehow flush out the system and get everything moving. What are we going to do to get better at implementation? Who do you know that is a world expert on scaling up massively complex health interventions in poor settings? If you know somebody, let me know. And I've been looking. So when I came back to Harvard, I asked a lot of people, who are the best folks in the world at implementation and delivery? And I kept getting the same answer. Well, it's the folks at the business school. They actually take a fiercely multidisciplinary, agnostic approach, get every piece of data they can find to try to figure out how better to extract surplus value from every corner of the world. It's not what I do. I don't try to extract surplus value. But the method sounded interesting, so I dug into it a little bit. And I also asked myself, why is it that we don't study delivery, implementation, scale-up in medical school? So in 1891, you can see that the theological schools were much better endowed than the medical schools. And guess what? Right around the early 1900s, a man named Gates began to have an impact in medical education. Frederick Gates was the pastor of John Rockefeller. And he read William Osler's book, The Principles and Practice of Medicine, and thought, wow, this is really exciting. They really are beginning to understand understand human physiology and pathophysiology. And so he told John Rockefeller, your fortune is rolling up like an avalanche. You must keep up with it. You must distribute it faster than it grows. If you do not, it will crush you and your children and your children's children. It's almost eerie reading and learning about this stuff because exactly 100 years ago, they were thinking about these issues. In 1906, they gave the money to build what is the current Harvard Medical School campus. And they gave tons of money and for both public health and medical sciences. Since that time, since the 1940s, of course, the NIH budget has exploded. And, everyone will tell you who's a basic scientist, and they're right. There's not enough money for basic science. But there's been an explosion of money over the last few years, and this is both necessary and it has to go. My own view is that the curve has to keep going up, and in fact, there's plenty of money for the curve to keep going up. $28 billion is about the equivalent of 10 weeks of the Iraq War. So in my view, it's perfectly affordable. But what this seemed to have done, along with the very conservative politics of the American Medical Association, is to subtly give us the notion that the science will cure the social. That if we just get to the molecular level and really understand disease, somehow doing the research and getting the new technology will solve all the problems of access. Well, I can tell you that today, the domestic delivery failures are pretty profound. Blood pressure control, 67% of patients in the United States have adequate blood pressure reductions. Lipid control for diabetics, 44%. It's worse than that. People with a heart attack, if you have a heart attack in the United States and you go to an American hospital and you get treated expensively for that heart attack, 100% of those people should leave the hospital with a beta blocker and an aspirin with some exceptions. 45% of the people leave the hospital with a beta blocker. And that's after intensive effort over the last few years to get that rate up from an even lower rate. The average amount of time it takes to get a new intervention or a new technique to the majority of the people who need it in the United States is 17 years. We haven't focused on this. There is no department of delivery and implementation in any medical school that I've looked at. And again, if you guys know, let me know. It's certainly not, it doesn't exist at Harvard. And of course, global health is much, much worse, our delivery problems. When we were at WHO, to the leadership of Tim Evans and Chris Bailey, they really tried to get their heads around this concept, the no-do gap. And I think it's a good way to think about it, what we know versus what we do. And what we did at WHO was to try to introduce knowledge management to global health. And Chris Bailey is a librarian by training, but an expert at knowledge management. And he was thinking of really brilliant ways of bringing knowledge to the people. I mean, the classic WHO way is to send out treatment guidelines. And so, that you go to a district health officers in an African country, and their desks are piled high with treatment guidelines. And if treatment guidelines and just getting knowledge to people were the answer, God, how great that would be. Now, I have to say, this was a huge, huge, huge advance and a very important development and needs to be done. Then, just about a year ago, a journal was started called Implementation Science. It was very exciting. Mostly focused on first world issues, but again, taking us another step. And this was not just getting information to a site, but it was making sure that that information got to that site and was taken up. Very, very important. What does it look like? Strategies for reducing the door-to-balloon time in acute myocardial infarction. Very, very practical approaches to save myocardium in the United States. This was done in the United States. An important study. But again, given the current track record, it'll take 17 years for that to get to the majority of the population. How do we get that down to 17 months in the United States and at the same time dramatically improve global health outcomes? I'm now working with this brilliant Harvard Business School professor who is, in 2005, he was called the most influential business thinker in the world, and number 2 was Bill Gates. So I was impressed by that. He says that it's more than knowledge management, it's more than implementation science, and he calls it delivery science. He says that it's not just getting knowledge to people, and it's not just taking something and doing it over and over. It's stepping back and saying, what's the overall strategy here? What are we trying to accomplish? And let me give you an example of how I understand that distinction. So implementation, a focus on implementation is what you could describe the DOT strategy. We had an intervention, we did it over and over and over again. We focused, and kept doing it. But DOTS didn't work for drug-resistant TB. And for TB HIV, it's also a problem because sputum smear microscopy has a terrible time detecting HIV patients with TB. So without stepping back and saying, what's the overall strategy, and thinking about every step in the process, we can miss things. It's not, I mean, the really advanced people in global health are saying, we've got an interesting implementation, it looks like it's going to work, we're going to change WHO policy and then scale it up. Right? Several areas there with magical thinking. And if it's just a single intervention, we're going to get into trouble. So we actually think, and when I say we, it's myself, it's Paul Farmer that are working on this, it's Michael Porter, it's Don Berwick, the guru of quality improvement. that inside medical education and public health education, there's room for an entirely new field. We do basic science very well, and we do clinical science better and better all the time. You have to remember, though, that clinical research 20 years ago was looked down upon. Are you kidding? Are you retarded? You're doing clinical research? Anyone who's not doing hypothesis-driven basic science research was looked down upon. So clinical research and clinical science have come a long way and are critical. Chris Murray in global health has brought evaluation sciences to that world along with his colleagues, and it's really gotten better. But what about delivery science? Where does it fit? So you've got these discoveries, and you found out how they work in the clinic, and you found out also that you're not delivering it very well. How do you solve that problem? Who are the go-to guys? There ain't no Ghostbusters of delivery science. And I don't want to trivialize it, but I've been looking, and if you guys know who these people are, please let me know, because I'd love to meet with them and talk to them. So what would delivery science do? Well, it would focus on a case study approach, but a case study approach very different than likely what most of you are used to in medicine and public health. The business style case study is very different. First of all, I think it's clear, and I believe that you can't study complex problems in delivery in any other way but through the case method. The methodology allows study of delivery systems over time and locations. The comparative part of this is really important. We can't just have one or two case studies. We have to have hundreds of them that look at successes and failures in HIV treatment, for example. You get detailed explication and analysis of program success and failure. I mean, these guys talk about operations in a way that I had never been exposed to in my talking with them. And again, completely agnostic, completely open to qualitative and quantitative methods. They use every bit of data they can find. What should we begin to study? Well, smallpox eradication. You know, Bill Foege, in my view, was responsible for smallpox eradication. And if you talk to him, he says, you know, I mean, when he sees Don Berwick talk about the Toyota production system model in quality circles, he says, you know, Jim, he told me, he said, you know, when I hear him talk, that's what we did in India. If you ask me what was the approach to eradicating smallpox in India, I'll have to ask you, well, at what point in time? Because it changed all the time. That's how they came up with the containment strategy that led to the eradication of smallpox. How many of you knew those details? This is a global health audience, right? You know, some of you did, right? Some of you did certainly, because you know we're in Bill Foege land. But everyone in this room should be able to recite it like a nursery rhyme. You know, Bill Foege had quality circles, and he, you know, it should be. It should be just absolutely common knowledge, and you should know the details of how that happened, but we don't. Why not? I think it's now time to do that. Jim Grant and child survival. How many people in here knew that Jim Grant stopped the war in El Salvador for 2 days in order to give immunizations to children? More people knew that, right? Extraordinary. What if we stopped the Iraq war for a week? That's $2.5 billion. That's enough for all the TB, HIV, and malaria, for all the TB and malaria that we would need money for. So, you know, these are amazing. These are amazing stories. HIV treatment scale. Are we capturing the extraordinary PEPFAR experience as we should? What an incredible implementation experiment that's going on right now. Are we capturing it? And of course, linking HIV treatment, HIV, TB, and malaria treatment with primary health care. These are all things that we need to know about right away. Michael Porter talks about the value chain, and we're doing this right now with HIV/AIDS in Rwanda, and it's forcing us to look at different issues than we did before. And the idea is that by continuing to collect these cases, we can somehow bring order to them, understand something about local specificity and global generalizability, and come up with principles of global health implementation and practice. You know, I think this is possible, and that people can be trained in this. We look carefully at the different programs at Harvard, and none of them come close to offering this kind of training, or even having the materials to teach this, this new science. By the way, I call it implementation science, but someone pointed out to me that, but you know, Jim, anything that calls itself a science isn't actually one. You know, political science, social science, library science. So maybe I shouldn't call it implementation science. But in a very straightforward way, I think it is. I think it's applying scientific method to problems of delivery and implementation. That's what these folks who do this say that they're doing. Let me end by just going through a case. What does it mean implementation and delivery. What does it mean to take money from an HIV-focused program, which is what we're doing in Rinkwavu, in Rwanda, with the Clinton Foundation? Now, the Clinton Foundation have been our great partners, not only supporting us financially, but also providing tremendous amounts of logistical support. So there's the sign on the right-hand side, and that's what it looked like when we got there. And, you know, we believe in planting. We believe in making a clinic look beautiful and enticing for poor people to come to. And frankly, don't apologize for it. This was the inpatient ward. This is what it looks like now. This is simple stuff, relatively inexpensive, simple stuff. This was the surgical suite. This is what it looks like now. Because, you know, in fact, making sure that people don't die, that women don't die in childbirth is one of the most important moral imperatives we face. And the fact that 500,000 people die, women die every year in childbirth, is frankly a stain on all of us. And we believe that offering obstetric services and surgical services is a basic human right. The formulary. And you know what? Under the encouragement of the Clinton Foundation, they hired a financial analyst to do a value chain analysis, basically, of our project in Rwanda. And we found out things that we never understood. Everyone has told us, partners in health projects, forget about it. They're gold-plated, they spend so much money, there's no way that you can have health workers or accompagnateurs or the community health workers in every site. Well, it's 9% of labor costs and 4.2% of overall costs. You know, we actually didn't know this because you have to be pretty good at doing financial analysis to get this information. Really important. And moreover, the cost of providing comprehensive care, and it's comprehensive. It's all those things that I've talked about before: HIV, TB, malaria, maternal and child health, vaccinations, and even food. Food is 20 to 30% of our budget because these people are, many of them anyway, are starving. So it turns out that the overall cost of comprehensive services is $13 in our project. The current expenditure on the left is $10 per person per capita, but the government of Rwanda has pledged to spending $25 per person per year, and that is with their own money. So we didn't know this. I couldn't have told you the cost per patient prior to having a financial analyst come in and do the value chain analysis. I just want to make 3 points to finish. First, I've talked a lot about a new discipline, talking with our business colleagues, but let's make no mistake. This is about a social movement. It's about social justice. And whatever it takes to move us towards social justice, we have to be ready and open to doing. 20 years ago when we started Partners in Health, Paul Farmer and I talked to each other and we made a pact. We said, you know, we're always going to be on the losing side. We're never going to have much money to do these things, but damn it, we are going to commit to each other that we'll continue to cry out in the wilderness that we have to improve and provide the full range of services to all poor people. I think we have a different responsibility now. I think the social movement has to take the next step and prove that this money can be used extremely well, and that the best thing that wealthy people can do with their money is to put it into poverty alleviation and health care. Secondly, a lot of young people in here, and I just can't tell you how encouraging it is to know that so many young people have made this conference happen. I want to say one thing to you, is that you've got to follow your passion. A lot of people say, well, what specialty should I go to in medicine? I say, well, I can't tell you. You've got to find out what you love. Because the one thing we don't need in global health are unhappy primary care doctors. We need everyone to be thrilled and exhilarated at what they do. And what I've learned from doing value chain analysis is that anthropologists and sociologists and nurses and social workers and everyone is needed if we're going to make this work. Everyone has their eye on a different part of the system, all of which need to work if we're going to deliver on our promises. Finally, I want to say that the role of young people, in my view, as an anthropologist who studies primitive cultures, as we used to call them, the role of young people is to identify that which is primitive about their parents' generation and root it out. So I look forward to the day when people will say about the work that Paul and I did, God, can you believe Farmer Kim? They only asked for $10 billion for HIV. You know, that's just like 4 weeks of the Iraq War. What a bunch of wimps. I can see that day happening. And the future that you can dream of is a future that my 6-year-old son will find himself in, and then have to dream beyond that. What about 0.7% of GDP for global overseas development aid? That would be about $75 billion, not that much. Again, you can calculate that in terms of the Iraq War, and it comes out to be maybe several months. And for $75 billion, the United States alone could provide for basic health care for the entire world, according to Jeff Sachs's calculation. I think that, I hope anyway, that I can't even imagine what you guys will dream up for the future. You know, this is the mission statement of Harvard Medical School, and a lot of medical schools and schools of public health have these kinds of mission statements. This is John. John is a patient who came to us in Rwanda with both TB and malaria. And what we've learned over 20 years of work is that simple acts of compassion and decency linked to rigorous analysis, research, and maybe even a science of implementation not only can make all the difference in the world to whole health systems, but we never should forget that for John, it gave him his belly back. Thank you very much.